this evening's lecture, and I especially appreciate that it came out tonight since it's such a beautiful evening. And it's still light out now. So tonight, we're having a talk by Dr. John Miller entitled Local Global Health, Helping the Underserved in Our Communities. Dr. Miller is Medical Director at Partnership Health Center in Missoula's Community Health Center. In addition, he serves as Associate Program Director for Clinic Operations for the Family Medicine Residency Program of Western Montana. That's here on this campus. Prior to moving to Missoula in 2011, Dr. Miller worked for 8 years on the Indian Health Service, for the Indian Health Service in Zuni, New Mexico, where he served as Director of the Diabetes Program and Director of Student and Resident Rotations. Dr. Miller is going to talk about local global health and how working with the Indian Health Service and community health centers can be a rewarding career, working with underserved people in the United States. So please join me in welcoming Dr. Miller for his talk.
All right, thanks. Can you guys hear me in the back up there? Great, thanks a lot, Peter. It's always great to be introduced by Peter. He is my father-in-law, just to let you all know. This is the second year in a row he's booked me on a night when the Lady Grizz have a playoff game, which I think is demonstrated by the size of the crowd, but that's great. Thanks for turning out. I appreciate it. I think people may not know exactly what to do with this talk as you're looking at it, local global health, and like turning it upside down on itself or something like that. But see if you can stay with me here as we talk about the definitions of global health and talk a little bit about how some of the issues that we talk about in global health transcend borders, whether it's here in Canada, some of those issues, or even some of the things that we have in common with the lesser developed countries. So looking at these definitions, one from the US Institute of Medicine, a little bit old, but 1998. But these are health problems, issues and concerns that transcend national boundaries. And they may be best addressed by cooperative action. So when we get to the Indian Health Service and talking about that, what do Alaskan Native Americans and Alaska Natives have in common with the indigenous people of Canada or Australia? We won't talk about that a lot. We'll talk more about how those issues are played out here in the United States, but a lot of the issues that we might consider are across national boundaries. Then the other, this other one from a text is about the application of principles of public health for health problems and challenges that transcend national boundaries. So what are some of the issues that transcend national boundaries? So when we look at this, looking at global health factors, what are some of the things that play out? There's certain things that predispose people to certain types of medical problems or health problems, whether it's their racial characteristics or an ethnicity, gender, age, so women and children are special risk for certain things, geographic location. We'll get a little bit of into that on the talk here. Then enabling, if people are predisposed, what are some of the things that help play that out for people and make it more likely that they'll actually develop some of the health problems that are common. So if they have poor access to preventive services, perhaps, or insurance, or lack of access to health care, once they develop problems, certainly complications and further problems can develop as a result of that. And then also enabling is homelessness, malnutrition that can result from food insecurity, poverty. Some of these factors are important to consider. And then there's certain things around need that really, they totally transcend borders. Issues around mental health, maybe it plays out different in different countries, different economies, maybe different levels of development, but certainly across the world, people are dealing with mental health problems. And then different chronic illnesses and disability. That's an issue, I think, actually, that Rick talked about last week in terms of the work that he's been doing in Peru. These issues are very important in all sorts of areas, as well as HIV and AIDS, which likely is on the agenda for Africa. I'm not totally sure about that, but so let's talk about food insecurity as it relates to the United States. And this is from a National Geographic article that's within the last year. It's a very moving article. It talks a lot about the problems of food scarcity in the United States related to poverty, and why is it that people in the richest country on earth are malnourished. And why is it that that leads to obesity? And that seems counterintuitive to a certain extent, but if you look back at 1995, maybe some of you weren't even alive at that stage, but 1995, looking at the dark blue here, these are higher rates, maybe 15 to 19% of the population were obese in these states that are dark blue, and then light blue, 10 to 14%. So then we fast forward 5 years, okay? Now we've moved from those states that were 10 to 15% of their population being obese, now it's 15 to 19%. And those that were 15 to 19%, 20 to 24%. So increasing rates of obesity across the country. 5 years later, it goes even further. Now we're up to 25 to 29% in the Deep South, and even greater than 30% in some states of the Deep South. 2010, okay, even further along, where there's a sizable minority of states that have greater than 30% of their population who are obese, which, you know, I don't know if you all know, but that's defined. It's basically a weight for a height, kilograms per meter squared. Now, I wasn't able to find 2011, 2012, 2013 with the same color context, so I didn't show that in here, but it would just show it continuing to progress, maybe not as rapidly over 1 year, but this continues to be an issue. So this CDC.gov obesity data is very interesting. You can follow through over this 15-year period and see how the nation is really transformed in the way people are built. So this breaks it down by county. I'm gonna have a lot of maps in this. I really like maps, so bear with me or enjoy it, however you want to think about it. So this looks at by county, okay? Now out west we have big counties. You know, like this county in Nevada, I mean, that's huge. That's bigger than some western states. But that's a place where the rates of obesity are greater than 31%. But as you can see, like looking back, remembering that previous state data, you can see that there's certain areas within the states that really inform it and make for higher rates of obesity within the state. Like up in Montana, look at that. You've got certain counties, 1, 2, 3, 4, maybe 5 counties that all are at the higher rate of greater than 29%. But a lot of them, like including the one we're in right now, have rates less than 26%, likely much lower here in Missoula. So that's something. Then you kind of look at that same map and carry it over to this map, which is the percent living in poverty. And you'll see a lot of those same counties where there was a lot high rates of obesity. It's very correlated here, you know, through the Deep South, like which particular counties you're not sure. But when you come up to Montana, up in Glacier County where Browning is, down in, I think that's Bighorn County, which is where Crow Reservation is. You can see there's different counties that are very significant. Down in the southwest where I used to live, where the Navajo Reservation kind of sits right there. You can see that there's certain counties where there's a lot of poverty and there's a lot of obesity that's correlated to that. Oh, sorry, wrong way. Then you look at food deserts, and this came from the National Geographic article from a year ago, and they make great maps in National Geographic. But this is like the same counties, food deserts. So these are places where there's no car or no supermarket store within a mile. No car, I'm not sure what that is. A car store, I guess. I'm not sure about that. But anyway, just the latter part, no supermarket store within a mile, okay? More spread out counties, it makes sense that they would be there. But you can see that there's certain places in the United States where it's really hard to get good food. Like where we used to live in Zuni, there was one grocery store, and it was about 30 miles from the nearest grocery store. And they actually had pretty good produce there. But it was only there because there was a lot of efforts to try to get good produce in that store because we're trying to address that. And that's in McKinley County, that's right down here. But so a lot of people have difficulty getting food. What's interesting here is there's actually a lot of food deserts in places where you wouldn't expect. And I guess it doesn't really show in this, on this map, so I won't go too much into that. But like Chicago, if we like showed Illinois and Chicago, that's actually in the article. There's food deserts in Chicago. There's places where it's really hard to get food in Chicago, or good high quality food that's not high caloric density sort of thing. Then we look at the percentage of people receiving food stamps, or SNAPs, okay? SNAPs is Supplemental Nutrition something program. You can't think of it off the top of my head right now. But as you can see, a lot of those same counties, high poverty, high obesity rates, food scarcity, food deserts, a lot of people on food stamps. All of these are correlated. All of them fit together to help explain the obesity epidemic and a lot of the medical, health and medical problems that are related. And so why is this? One of the issues has to do with farm subsidies and how our government supports certain agricultural industries to create, grow a ton of corn. We grow a ton of corn, so high fructose corn syrup is in a lot of different things, and a very high caloric density helps lead to obesity and development of diabetes. And then it shows some other things where there's a lot of subsidies for certain crops. And then it has the effect, this article, or this slide, which is also from that article, talked about how these food subsidies have an effect on our diet. So the huge amounts of sodas, energy drinks, sports drinks that people drink that have or that are available at a much lower cost because corn is subsidized. And then there's other ones along the way, so different grain-based, meat-based, and mixed sorts of things. Chicken is available for very inexpensive. It's very available. So my interest in this really comes from partly it started when I was growing up. I lived for 3 years in the Four Corners region of the United States. Actually, where the Green and the Colorado come together is a cool town called Moab, Utah. And I lived there before it was kind of a mountain biking destination sort of place. And my mom worked as a social worker in Four Corners mental health. So she did counseling and helped people get connected to services. And she worked a lot down kind of in the Utah part of the Four Corners area. So the Four Corners is the only place where 4 states come together in one place. You can like do a push-up there with one body part in each place. It's kind of cool. And this shows the Navajo Reservation. And my mom worked in that area, and she'd often take us along, and some of my earliest memories are related to that, and also some of my comfort foods. So one of the things is Navajo Frybread. Okay, this is going to tie together, so hang with me here. But Navajo Frybread tastes really good. Up here, I think they call it Indian fried bread, maybe, or it's called different things, different places. But it started actually in Navajo, related to a dislocation in the 1860s where they were moved about 300 miles and they were kept for 3 years at Fort Sumter, and they were given just a limited number of things, and they figured out how to make Navajo fried bread. And it's really good. This is one of my favorite dishes. Navajo taco is what we called it in my family. I think it's Indian taco here. A little bit of dessert. You got some Navajo fried bread with some sugar and cinnamon. And then you can have it with honey. You know, there's some really good options for Navajo bread. I'm not joking. These are my comfort foods because I grew up there. Whenever I go see my mom, she makes Indian tacos, and we have this for dessert. So forced changes in the diet. This is really how I'm trying to tie this together and talk about how Navajo Frybread came about. You know, historically, prehistorically, they were hunter-gatherers. They were the first to get horses. Before that, they ran everywhere. They hunted. They killed game. They scavenged for different things that they could eat. Really high energy requirements, like they would cover huge distances. They would run 20 miles per day for 5 days in a row, this kind of thing. And they'd have cycles of scarcity and plenty, okay? So times when they would have very little and they'd have to survive on very little for a long time, and then they'd kill like not down there, they wouldn't kill buffalo, maybe they would kill actually there were some buffalo in New Mexico, they went that far south, but they'd kill that and then they would have plenty, they would eat a ton, and then they would prepare themselves for the next period of scarcity. So that's kind of historically how the native people of the Southwest, and actually a lot of the native people in the United States and Canada and Australia have lived. Then they get planted to places, they're given government supplies, which back in the 1860s included lard, flour, salt, sugar, baking powder. If they got all those things, maybe they got just some of the ingredients. And so yeah, it was the Navajo long walk, so 300 miles to Bosque Redondo over a 5-year period that they were basically imprisoned there. So Frybread developed there, but it's been used in different places. Navajo Frybread, Pueblo Frybread. So the Zuni made Frybread, and they called it something different. And then up here, I think it's called Indian Frybread from the different times I've been exposed to it. So next, my exposure to the Indian Health Service was up in Browning, Montana. So as a resident, to become a doctor, you go to college, then you go to medical school, and then you go to residency. And in family medicine, that's a 3-year residency. And often they have rotations in kind of smaller towns, rural rotations. And actually, at our program here in Missoula, we have rural rotations in 9 sites. One of our sites is in Browning. Part of the inspiration for that was that my wife and I did a rotation in Browning, Montana as 3rd-year residents, and it was a really great experience. This is a picture of Browning. It actually snowed August 12th when we were there. Generally, the weather was really great in the summer. It was really beautiful up there. And the access to Glacier National Park was fabulous. It was great for outdoor sorts of things. Really enjoyed that. One thing about Browning is it has really high winds. Promised a lot of maps. This has really nothing to do with health, at least obviously, but you can see this front range of the United States, or the eastern range of the Rocky Mountains has really high levels of wind, and that's where in Browning there's a lot of wind, and we're kind of sheltered from that in the middle of the mountains here in Missoula. Okay, back to Browning. They would rodeo. We got to go to a lot of rodeos when we were up there in the East Glacier and in Browning. And they also had an overland horse race, which was very cool. I think they raced, maybe it was 10 miles or something. It was on a weekday in the middle of the day. It was very interesting. And it included a swim across the pond. So the folks we were working with is like, you have to go to the pond. And so we went to the pond and they ride up to it. They swim with their horses across and then they go on from there. It's a very interesting place to be, and we would have loved to work there, but my wife and I both wanted a job. So we looked other places in the Indian Health Service, and we ended up in Zuni, New Mexico. So Zuni is in McKinley County down here. The Zuni actually ranged from the other Pueblo nations. They kind of communicated with them, shared with them, all the way to the Grand Canyon. They would run huge distances, cover great distances, but it was centered in Zuni. Their people were centered in Zuni. A lot of overlap with the Navajo, or completely different culture. Navajo had a lot of horse culture. There's a lot of rodeo in Navajo. Zuni, they don't really do anything on horses. Maybe a couple people that I know, but they do a lot of farming. And as a Pueblo, they actually built up around kind of the middle rather than being spread out, and did a lot of cultivation that I'll show you here. It's really beautiful down there. Not so different than here, very arid, dry rock formations with trees, smaller trees there than we have here. And this is a historic picture of like the first skyscrapers in the United States. So these are 900 years that they'd been living, 2, 3, 4, 5 stories on top of each other, really crowded around the center for defense against the Navajos and Apache, mostly. And so they did their farming, they lived together, just kind of in the middle, in the Pueblo. And this is a picture of the way they used to grow food. These are called waffle gardens. So they're kind of different squares that are indented. They would capture any rain, but it doesn't rain there very much. So it involves hauling a lot of water from a river that usually had water. So they'd have to grow their own food there. And so, again, a lot of energy expenditure, probably times when they didn't get a lot of rain and didn't get a lot of crops. They would have to go try to get deer or elk, other ways to feed. So again, there's still is a period of kind of feast and famine, plenty and scarcity that they went through. So we worked at the Indian Health Service Hospital in Zuni. It was a beautiful facility. We were all family docs there, so we delivered babies, took care of people in the hospital, staffed the ER. It was a really great experience working there. Enjoyed it a lot. I worked as the director of the diabetes program, and diabetes is a big issue down in the Southwest for Native Americans. And also for Hispanics down there as well. You can see here the rates of diabetes by race and ethnicity in the United States. So whites have the lowest, kind of Asian Americans, non-Hispanic blacks, Hispanics, and then Native American Alaska Natives have the higher rates of this group. Diabetes in Native Americans really varies by geography. So down in the southern Arizona, so like around Tucson, up to a third of the people of adults greater than age 18 have diabetes. Here in Montana, it's kind of more in the middle, 16%, about the national average. Interestingly, the rates are very similar in Alberta, so among the Canadian Aborigine population there, and then also among the Plains Indians, so like in North and South Dakotas, typically hunter-gatherer prehistorically, and so there's some of periods of scarcity, this kind of thing. Alaska Natives, interestingly, have a lot lower rate. So it really varies by region. So people say, well, why is that? Why do so many people in Zuni have obesity and diabetes? And there's a lot of different theories related to it. When we were there was a lot of stock in this thrifty gene theory. So the idea there is that people live through periods of scarcity and plenty. If you have good genes, you can survive times of like extreme scarcity by storing extra calories really well. So then if you're in a time of plenty, plenty, plenty all the time with, you know, the different high caloric foods that people eat now, there's, you know, these folks store it really well. So that's one theory that has a lot, kind of long legs and has gone a long way. Another thing is historical trauma. So folks who are displaced, I was talking about the Navajo Long Walk. There's also issues of folks, Native Americans being kind of taken off the reservation, put in boarding schools. There's talk about DNA changes called methylation. It's kind of a biological thing where actually it's inheritable DNA changes that make people that people get from stress, and so that they pass down kind of the things that happen related to historical trauma. And then there's social factors that are common, and that gets back to those slides about obesity and poverty and food stamps and food deserts and all of this sort of thing, that you know, poverty and food scarcity and insecurity are very high in these areas. One thing that's really cool is the Pima Indians are genetically the same. The folks who live up by Phoenix, in the Gila area, and these folks who live down in Mayakoba. So in 1860, these folks said, boy, it's really changing up here in Arizona. We're going to go south down into the mountains of Sonora. And they maintain a lot of their traditional way of life. And as a result, you end up having two groups of people who are genetically very similar, basically the same, who have very different traditions, very different rates of obesity and diabetes. And so this is a picture from a horse parade, kind of a way to celebrate in Sonora. And this is a ribbon cutting at a bingo hall casino near Phoenix. And you can just see like the difference in the people, and it's just two totally different cultures that come about from different ways of life, different levels of activity, different levels of access to high caloric foods. Yeah. So what about Montana? So Montana Native Americans, they make about 5% of the Montana population, and on the US average, it's a lot lower, so like 1.3%. So there's a lot more Native Americans per capita in Montana than a lot of states. It's not the highest, but it's pretty high. The Indian Health Service has multiple hospitals throughout the state, and then tribal clinics also. And the health expenditures per capita are really low compared to the healthcare that's spent on non-native folks in Montana, or actually in the US is the comparison here. So here's a picture of the reservations in Montana. So the Blackfeet, where Norris and I did our rotation. There's also the Flathead, which is kind of a mixed reservation up in the Flathead, obviously. Rocky Boy, Fort Belknap, Fort Peck, Crow, Northern Cheyenne. This just gives you a sense of where they are in Montana. So a little bit more about the Indian Health Service I wanted to share with you. It was established in 1955 to help meet treaty obligations. So there were a lot of treaties in the 1800s where there were different promises. One of the promises at one point was for health care, and the US government decided to meet this treaty obligation starting in 1955 by founding the Indian Health Service. There were different kind of Indian health clinics prior to that, but they weren't organized under one administrative body. Interestingly, the Indian Health Service actually serves less than half of the American Indian Alaska Natives, and there are those residing on or near the reservations, because the healthcare, the tribal clinics and the Indian health hospitals are on the reservation, and the majority of Alaska Natives live remote from there, like in Missoula or other cities or other places in the state and in the country. There's unfortunately kind of a low budget. It only represents about 50% of the needed funding. One of the things we'll talk about later is contract health services, and those money run out early on at a lot of Indian Health Service hospitals. And like I said, it's just not accessible geographically to a lot of people. So there's a lot of health disparities related to IHS that I thought we would just mention here and talk about. So really high rates of alcohol abuse, so 6 times the overall US population. We certainly saw that in Zuni and in Browning. Hospitalization rates for alcohol-related conditions are much higher. Injuries are a significant thing, often related to alcohol, so both unintentional and intentional injuries from like car accidents. We saw a lot of that working in the ER there. And then mortality rates related to homicide and suicide. But we didn't see so much homicide in Zuni, but we did see a fair amount of suicide when we were working there. And then chronic diseases like diabetes are a much higher rate than US population. And the death rates for heart disease, that's partly related to how highly treatable heart disease is through a lot of the more recent technology, and so limited access to healthcare is a big part of why there's a higher death rate from heart disease. And then there's higher rates of kidney disease, partly related to diabetes, because that's a complication of diabetes, but there's also apparently a kind of a genetic predisposition, at least among the Zunis, where actually it's a 60 times increased risk of developing kidney disease in Zuni. And we had a huge dialysis center. We had a lot of patients who had kidney disease, both prior to dialysis and then end-stage renal disease who are on dialysis. So the challenges, it can be challenging to work on reservations. There's social inequities. There's a lot of poverty in some of these places. There's a lot of unemployment. A lot of folks, I think there's a lot of pride in graduating from high school. Some folks go to college, and graduation from college is relatively rare, or less likely, less common. Less than half are likely to graduate from college. One interesting thing is kind of cross-cultural communication. So there's 565 distinct tribes with unique customs. So we saw that in Zuni, where we would care for both Zunis and Navajos, who were completely different. They both had different languages, neither of which I spoke, and it was really interesting. Like, one difference was Zunis. Like, if you'd walk into a room where there's Zunis, there'd be laughing and all of this kind of thing, and Navajos are kind of more serious, and so there's some kind of cultural clash there. Sometimes when Navajos would come in the hospital, they would be kind of offended by the Zunis laughing so much when people are sick around them, kind of thing. I don't think the Zunis meant anything by it, but it's just kind of one of the realities. I kind of find it hard. I'd play basketball with them, and they're all a lot shorter, and they're really quick. I can't say they're that great at basketball, but they're like great runners kind of thing. But they laugh all the time. So they're like, you miss a shot, that's really funny. It was cross-culturally, it was kind of a different sort of thing that you have to, living there, you get exposed to. The different languages are interesting also. So the Zuni, the young people, the middle-aged people, the elders, they all speak Zuni. It's a language that's very intact. It's being maintained. There's a lot of pride and protection of the language. Whereas the Navajo, like, almost all of the elders spoke Navajo, and maybe even not English. And then very few of the young people spoke Navajo, but they spoke English. And so we got like this middle generation is they're the jugglers language-wise in the families. It's just really interesting. We'd often have to use interpreters working with Navajo patients, but we would rarely need that for Zunis because they're mostly bilingual. The other thing about this in terms of access to care is, we saw on the map the huge counties where, or the reservations, and we'd have people like Navajos kind of surrounded the Zunis, and we'd have people drive an hour, and it's only 20 miles. But it's, on dirt roads. If it rained or snowed, they're not making it. Tough conditions. Long distances with gas prices, it's expensive for them to get to care. It's really challenging. And then physician recruitment is a big issue in the Indian Health Service. So if any of you become a physician, please consider working in the Indian Health Service. It's very rewarding. But there's very high need. We actually had a lot of good providers in Zuni, partly because of the way it was run. It was a good place to work. We had good recruitment and retention, but not all Indian Health Service hospitals or tribal clinics are that way. There's a lot of opportunities. This top thing, so kind of community partnership. So as the diabetes program director, I would work with the local tribal groups that were working on what was called like kind of healthy lifestyles, an idea of kind of getting back to what are the things that we used to do in terms of eating more healthy, being more physically active, trying to support people in a culturally appropriate way. really interesting sort of thing. One of the things I really enjoyed was a fitness series. It was called the Zuni Fitness Series. You know, it's not kind of a historically maybe sensitive sort of thing, but it was great. We'd have a race every month, a 5K, 10K, half marathon, and a lot of really amazing runners, and it was really fun to try to keep up with some of them. DIPS is like a dive-in prevention strategies, and it's kind of working with people who are pre-diabetic, obese, to try to get more healthy eating and activity level. I already mentioned healthy lifestyles. And then in women's health, trying to get pap smears for cervical cancer screening, mammograms for breast cancer screening, trying to reach out to kind of more sensitive subgroups within the population. A lot of community outreach, like kind of story circles where people would talk about what they went through, and it helped people, okay, yeah, I can go up there to get my pap smear or get my mammogram, that kind of thing. We also, in the Indian Health Service, and I cited an article that's in the syllabus, that article talks a lot about what the Indian Health Service has done to really change the way that healthcare is designed and delivered. So group visits, when we were there, we started group prenatal, so women who are all due at about the same time would meet together and they'd share stories. It's a lot better than me telling them how to deal with pregnancy as a male. It's better for me to try to facilitate their discussion. Same thing with group diabetes. It's more helpful for them to talk about the changes they made to control their diabetes. And then group well-child visits, talking about kind of healthy, safe parenting sorts of things. So group visits were really fun. It's different. A lot of, let me see, I think in partnership, we're the only clinic in the city who are doing group visits. We're doing group diabetes visits now. No, that's not true. There is one other clinic that's doing that. Patient-centered medical home is just kind of a model sort of thing around medicine, that kind of a way that care is organized in teams, like to try to help nurses play a bigger role, not rely just on doctors to tell everybody what to do. Instead, you have kind of people working together. And then the technology. The first electronic medical records were in the Indian Health Service. Actually, the earliest ones were in the VA, the Veteran Affairs Administration. I think the VA gets a lot of bad rap, but they actually were the first ones with an EMR in this country. Now so many clinics have electronic medical records, these kinds of things. Other opportunities, there's a lot of support for recruitment and retention, so different scholarships, different groups that try to staff the opportunities on the reservation. So that was the end of our time in Zuni. We had a really great experience there. And then thinking, like, what do you do next when you've worked in the Indian Health Service? And so working with the uninsured seemed like a logical next step. I don't have the key in terms of what these show, but basically there's areas where there's more people without insurance than other areas. And that coincides with the states under the Affordable Care Act that have not acted on Medicaid expansion. So that was just recently voted down in the Montana House Committee. So a little less than half of the states have not expanded Medicaid, so insurance for the kind of poorest, less than 133% federal poverty level, which is incredibly poor. Folks who cannot afford coverage or access to medical services, and it just coincides with the places that are more impoverished and higher levels of uninsured. So working in community health centers. Community health center movement was started to try to provide care for people who don't have insurance, who don't have access to a lot of the different opportunities. This is a little bit dated, about 3 years old, but serves a lot of patients. As you can see, kind of higher percentage of blacks and Hispanics, other minorities, offers primary care and prevention, challenging it can be very challenging to recruit and retain physicians because there's a lot of need. Folks with very complex medical problems who it's hard for them to get in because it costs them money to get seen. Luckily, they're seen on a sliding scale based on their income, so if they don't make very much money at all and they can verify that, they can be seen, actually a partnership health center, they can be seen for $15 for a visit. It kind of goes down from $150 to $15 depending on how that is. Rural health is a big thing in Montana here. There's a lot of poverty in some of these smaller towns that are here. The limited distances, kind of like what we talked about for the Indian Health Service, apply for folks who live in small ranch towns or not even in a town, but on a ranch remote from a town. The topography, so getting over passes can be hard. The weather can come up at different times, and then there's just the availability of healthcare in some of these smaller communities. So there's 11 counties in Montana, so there are 56 counties in Montana, right? People know that. 11 of those don't have a physician. 54 of them are health shortage areas or primary care shortage areas. And so there's a real need here in Montana to train rural doctors. The National Health Service Corps helps pay for folks to work in places where there's a higher need, either through a scholarship where you get paid while you're in medical school and then you have to pay back, or as a loan repayment, you get the loans while you're in medical school and then you go work somewhere where you can get some additional money to help pay off your loans. The way they figure out which places deserve National Health Service Corps and other different types of programs are these health professional shortage areas. This was developed a long time ago in 1976, and it's based on geography, population groups, medical facilities. And so actually Missoula County Partnership has a very high HPSA score. You might not think that because it's in Missoula where there's a lot of doctors, but it's historically been very hard to recruit and retain physicians at Partnership. So that's just something to know. And I'll show you a map later of Montana that shows some of the high HPSA scores that are there, and that has to do with them being more remote or poor counties, yeah, I think that wraps it up. So here's the HPSAs by counties, okay? So these are, HPSA score are 19 to 25 is like the highest level. Partnership last year was 19, but in general, Missoula County, the HPSA score is very low. It's just because our clinic is such a high need, 14 to 18 in different counties. But you can see that this highly correlates to the poverty, obesity, the other maps that we saw earlier. There's just a high need for medical services and insurance in these areas, or access to care in these areas. So the community health centers in Montana, so the kind of the crosses here are, Partnership. They started a community health center in Superior that's likely going to become there's actually a plan for it to become a satellite of Partnership. There's Helena, Butte, Libby, Kalispell. I'm not sure what that one is up in Glacier County. Cascade. Oh, no, yeah, that's the Indian Health Service Hospital, is the square. And so the different Indian Health Service facilities, Lewistown, Billings, Hardin, this kind of place. So I think Ashland is one of these towns out here. Miles City, I think, is that one. I don't know the eastern part of the state that well, but there's 17 community health centers in Montana, kind of distributed throughout the state. Tend to be in larger population areas, and people have to travel great distances. So at Partnership, we have folks drive from. I've had a patient from Noxon, and Big Fork, Phillipsburg, Anaconda, and then Darby, Sula, pretty far that people are driving for healthcare. And in partnership. What else is on this map that's kind of interesting? So looking at the different counties where there's higher HIPS, lower income, and then geographically they have higher HIPSA scores just because they're geographically isolated. So like up in Sealy Lake has a higher HIPSA score. Around Phillipsburg, Drummond. So kind of interesting map there. So I was recruited and happy to take the job to become medical director at Partnership Health Center. Part of it for me was to help change the clinic from a place where it had been a place where recruitment was tough, retention was difficult, to a place where I think we are right now. We moved into a new building, doubled the size of the building through different grants. It's a beautiful facility that we have there and provides beautiful care to the patients, or a beautiful setting for care to the patients. We also have a clinic at the Poverello Center, a homeless clinic in town. And we started the first school-based health center in Montana. So that's a big movement, like in Seattle, Portland, other places, and we're the first clinic in Montana to do it. I don't have a picture of but next to Lowell Elementary, we have a clinic where we staff that and have better access for those students who it's been shown to decrease absenteeism, help with academic success to have a school-based health center. So the partnership mission, I'm going to show you some mission sorts of things around community health centers and our residency program, and it's really about accessible, comprehensive care to the medically underserved. The underserved, people who are not, they don't have, a lot of them don't have insurance. You can go there if you have insurance, but the majority of people seen in partnership don't have insurance. The majority of people are less than 100% federal poverty level at partnership. But there's also like 12% of the people have Medicaid, 12% have Medicare, and 12% have private insurance. So it's kind of a mix of folks. And I'm digressing a little bit there. But anyway, it's a powerful mission that I was happy to work with. Also, as a part of it was to start in the clinic, a clinic for the residency program. So Peter mentioned that I'm the clinical director for the residency program. And the mission for the residency program is to train motivated, clinically competent, compassionate physicians to work in rural and underserved areas of Montana. So that fit really well with where I was coming from. And so we do some of our training in rural areas. So we went to Plains and did kind of simulation, working with like how to revive a baby when they're first born, sort of is the program. And it's great. We get the training out in the areas where we're hoping that they'll go to work. Also, we do a lot around teamwork, communication, working together. This is a picture I really like from the Missoulian, so I threw it in there. I'm going to get it framed because it's very cool. And there's a lot of untold stories here because it's in the old clinic and now we're in the new clinic. This is like the first day or the first, the Missoulian reporter came. It was very cool. So I was very excited about the mission, the opportunity to help partnership move into this new realm of helping to train the next generation of family doctors. So I just wanted to bring this to you, talk about local global health, talk about some of the opportunities to work with the underserved in this area. There's the Missoula Indian Center. So for urban natives, there's some services available through that center. The Poverello Center for the homeless, there's a lot of volunteer opportunities there, as well as intern opportunities. There's also a migrant clinic during July, during the cherry picking season. It's very transient. It's there for just a couple of weeks and then it's gone. But there is some opportunities to work in these places. Partnership, we're working on developing our volunteer opportunities for college students who are interested in health careers. Right now it's not really developed, but so stay tuned on that. Critical access hospitals, so little hospitals in towns like Superior, Montana, Plains, Ronan, Hamilton, Anaconda, you got the idea, small towns. Places that have a huge amount of need, and if you're interested in a health career, it's a great place to go enter, help get people to where they need to go as kind of a tour guide or that kind of thing. I'm blanking on it right now. And then there's tribal clinics and IHS hospitals throughout the state here in Montana that I think provide really great local opportunities to get involved with global health issues. So you don't have to fly to Africa to get involved in some of these issues that you've heard about in this course, all right? So with that, I'm open to questions if anyone has any. Yeah?
How many residents are you currently training? What's the goal for your program?
Yeah, so I didn't get a lot into the residency program, but it's very cool. I'm happy to talk about it. So I was asked how many residents are we training. So we're training 10 per year. Montana, before we started our program, ranked 50th in the country for the number of trainees in medicine who per capita, and it turns out that where people train is where people end up working, so it's kind of a big thing for our primary care shortage in Montana. So we have 10. Everyone's, the 10 start in Missoula, 7 stay in Missoula, 3 go up to Kalispell, and so we'll have 24. Next year we'll be at our full number. We actually find out next week who those folks are going to be. So we'll have 24 in Missoula and 6 in Kalispell. And then they do rotations in small hospitals, the critical access hospitals, and in Browning. Yeah?
Why do you think poverty is so invisible in this country? I mean, it's very visible to you, but many of the comments after Hurricane Katrina in 2005, people had no idea that kind of poverty existed in America until it started in Florida. What's your opinion on why it's so invisible?
Yeah, so why is poverty so invisible in the United States? I think there's still a lot of segregation, maybe not with the capital S like prior to, Jim Crow or something like that. It's not exactly like that. But I think there are pockets of poverty that maybe are more isolated and people don't see them. Like certainly on reservations, if you go there, you can be very impressed by the level of poverty that's very visible, but how many people go to reservations and see that? Or if they do, they're like, this place, they don't have a context for it. And no, I think there can be a lot of blame of poverty. And then I guess also in cities and rural areas also, so it's not just cities. I think it tends to be that people are kind of the available places to live for impoverished people are maybe remote or not seen by the others. I guess that'd be my answer. It's not an easy question, but it's obvious to me because I work with these populations, living and working on reservations, and particularly on the north side, the homeless population in Missoula, and then just the huge numbers of people we see who make less than 100% federal poverty. I mean, it's incredible how little they have to go on. And so when we talk about medications or testing, like there's just huge consequences to anything that you talk about with patients, and it's a really interesting part of our job to help talk about how can we really help them, not just give them a prescription or something like that, but talk about the different problems that they face, try to put yourself in their shoes, that kind of thing, even though you couldn't. How about other questions? Yeah.
Why is it so difficult to get physicians and other healthcare workers to go to some of the more rural communities? Is it they don't have facilities, or the pay scale's low, or they're the only guys there and they go wore out? What's going on?
I hope people heard the question and what some of the posited reasons were, because he knocked off a couple of them. So yeah, those are good thoughts. Other things are that, because it's remote, people are married, professionals are maybe married to other professionals, and is there a job for both people in a certain place? It's kind of easy for us because we were both doctors, but other folks who may be doctors related to a university professor, that's just, it's not going to happen in a rural area for that person. And those are common, that those relationships are there. There's actually a very cool study going on called the Community APGAR scores. It's kind of an idea of what are the things about communities that make them attractive or less attractive to people coming from the outside to work. And part of it is to say that some of these small towns are incredible. They're beautiful, like Ronan is right in the Mission Valley, right pretty close to a lake. There's some beautiful things about different communities that, like, if they can use those to help recruit and then retain the folks, and maybe they can overcome some of the difficulty with, and then we need to train them. We need to train them here. We need to train them there, where they do rotations there, so they have an idea of what it would be like to work there. And hopefully our graduates will go work in places that have had challenges recruiting people. Yeah, Peter.
What are the advantages of training doctors versus training something less than a doctor, like a physician's assistant or something like that, who might actually live in those areas to begin with and not have to move into those areas?
Yeah. That's a great question. So why train physicians? Why not train physician assistants or nurse practitioners? And I would say, yeah, I think all of those are very valuable. One of the things I didn't touch on, but almost included, are rural clinics. So there's rules about how PAs can work in relation to their supervision by physicians, and there's special rules for really remote clinics, like the one that's at, the junction between 200 and the one that goes up to Troy or Libby, this little tiny junction. There's a clinic there that's staffed by a PA. There's a special federal rule that allows remote supervision, allows them to bill at a higher level in order to support that clinic. So yeah, PAs are definitely part of the solution. So are nurse practitioners. Part of it also is part of your question was to say, why are we trying to recruit physicians to this other place? A lot of these physicians that we're recruiting to our program are from Montana, or they're from rural areas. That's part of what motivated them to become family docs and want to do their training in Montana, because they want to live here and get started on that. So it's not that all physicians are from other places.
What's the chances of using remote telemetry, internet access for healthcare providers in smaller communities, so they can maybe get the supervision or seek additional information from better trained healthcare providers? Is that something that is it being explored in rural communities?
Yeah, so use of technology to help with supervision, ongoing support, clinical decision making. Yeah, that's all being developed. That's a big part of helping to provide support for folks who work in more rural areas. And then also part of trying to provide access. So specialists, I just read a newspaper article about an orthopedic group in Laramie who they fly all over the state to, serve the people of remote Wyoming. But there's also places where the clinic maybe has a relationship where they call and kind of set the table for those sorts of referrals to take place. Maybe if you connect by TV, then the person can know that it's worth driving to, all the way to Missoula to get their tests done.
Well, I think we're out of time, but John will still be here for a few more minutes after we conclude here. If you wanted to ask a question of him, please come forward and do that. Thank you very much, John, for bringing some of the issues that we've been struggling with, challenging for us in terms of global health closer to home. I think that's a very important perspective, and I think it fills out this lecture series in a very nice way. I want to just also mention that, I didn't do this in my introduction, that the whole lecture series really is partly here because of John's initiative. It was John, as the current chair of the External Advisory Committee for the minor in global public health, who really wanted to see us do this lecture series again after last year. So we owe him a double debt of gratitude. One, because we have the lecture series, and two, because of his fine lecture here this evening. So please join me.
Thank you very much.
So next week, you have a lecture by Charlotte Kutch, who is a dermatologist at the Western Montana Clinic. And she's going to be talking about teaching dermatology in Cambodia and what Cambodia taught me about public health. Charlotte gave me this topic several months ago, and she told me I wouldn't be available to give my lecture until March 18th at the earliest, because I'm going back to Cambodia again. So she should have some very fresh information for us on her experiences in Cambodia. So thank you again for coming tonight. I'll see you next week.